Now for our final abstract, and now we're moving tack to a benign disease, and I think this really highlights the richness of what we have at EHA in focusing on all aspects of hematology, from basic pathophysiology to different modalities of malignant disease to benign hematological disease. I'd like to invite Professor Franco Locatelli from La Sapienza in Italy, who's going to present, again, a very exciting late-breaking abstract, Efficacy and Safety of Single-Dose CTX001 for Transfusion-Dependent Beta-Thalassemia and Severe Sickle Cell Disease. Thank you very much for presenting this at EHA this year.
Thank you very much, Professor Almeida, for your kind introduction, and good morning to everybody. Today, I have the privilege and the pleasure to present on behalf of my co-investigator the results of genome editing targeting BCL11A in patients with either thalassemia or sickle cell disease, and these are my disclosures. Few introductory background remarks just to explain the rationale at the basis of this innovative therapeutic approach. When a child with either thalassemia or sickle cell disease is born, it doesn't initially need a transfusion or develop the symptoms related to the disease. And the reason for this is that the patient benefits from the residual synthesis of hemoglobin F, which is the predominant hemoglobin during the fetal life. And there is also an inherited condition called hereditary persistence of hemoglobin F, in which patients, despite the fact that they can inherit also the thalassemia gene or the sickle cell disease gene, do not develop the clinical signs of birth condition because of this increase hemoglobin F. And we know very well that a molecule coded by a gene located on chromosome 2, namely BCL11A, is responsible for the silencing and the synthesis of the gamma chain. So the line of reasoning at the basis of the approach was that of inactivating this gene through the CRISPR-Cas9 genome editing approach with the specific erythroid-restricted inactivation of the production of BCL11A. After two seminal cases published at the end of 2021 in the New England Journal of Medicine, further patients were recruited into two trials, namely the CLIN-THAL-111 or the CLIN Sickle Cell Disease 121, which are phase 1, 2, and 3 international multi-center open-label single-arm pivotal study of this drug product formerly known as CTX001 and now called exa-cel. The primary endpoint for both studies reported in this cartoon, and you can see that the goal was that of estimating the proportion of patients who become transfusion independent if affected by thalassemia or free from severe vaso-occlusive disease if affected by sickle cell disease. And the age range of patients recruited is between 12 and 35 years, and both studies were planned to recruit up to 45 patients, and the enrollment is already completed. Today, I'd like to present the data on all patients who were infused as of February 2022, namely 44 patients with transfusion-dependent thalassemia and 31 affected by sickle cell disease. In terms of efficacy, 42 out of the 44 patients, namely 95%, reached transfusion independence. And the 2 patients who didn't reach transfusion independence had a 75 and 89% reduction in the transfusion volume. And the results are sustained over time. And you see that, for example, in this first patient, the follow-up is even longer than 3 years. In the 31 patients affected by sickle cell disease, the success rate was 100% because all the patients were vaso-occlusive-free after exa-cell infusion, with a duration of the follow-up from 2 to 32.3 months. In terms of safety profile, it is consistent with that of a busulfan-based myeloablation followed by the infusion of autologous stem cells. In particular, no patients died or developed secondary malignancies or myelodysplastic syndrome. There were 2 patients who developed an SAE, in particular, 1 patient with TDT had 3 severe adverse events related to exa-cell, many occurring in the context of secondary HLH, hemophagocytic lymphohistiocytosis, or macrophage activating syndrome. And the 2nd patient had a delayed recovery of both neutrophil and platelets. So the safety profile of the approach is certainly reassuring for the patient. So in conclusion, the data from these 75 patients with either transfusion-dependent thalassemia or sickle cell disease show that a single dose of exa-cell leads to early increase in hemoglobin F and total hemoglobin that are sustained over time. 95% of patients with TDT stop erythrocyte transfusion, and all the patients with sickle cell disease are free from vaso-occlusive crisis. The safety profile is consistent with that of an autologous transplant preceded by a myeloablation. And thus, we conclude that exa-cell has the potential to be the first CRISPR-Cas9-based therapy to provide a functional cure for patients with thalassemia or sickle cell disease. Thank you again for the opportunity to present the data.
Thank you. Thank you, Professor Locatelli. I think we'll agree how exciting this is. For many years, we've been looking for cures for these debilitating hereditary diseases, and now that the light is in sight. Are there any questions?
Annette Brindle from BioWorld. So how long, you say it has the potential to be a functional cure. How long would you have to see to say, okay, this patient is cured?
So, the results that we have observed are durable over time. Mm-hmm. No patient who reached transfusion independence or freedom from severe vaso-occlusive crisis relapse, and also looking at the persistence of the edited alleles evaluated in both peripheral blood and in the bone marrow, the percentage of the edited allele remains stable over time. Mm-hmm. Thus, we can conclude that the results are durable, and we do not predict that that patient should lose the therapeutic benefit from the approach. Okay. Thank you for asking.
Sure. I have more questions if there's time? Okay.
Yep.
So just to clarify for myself, you think that the adverse events were due to the bone marrow conditioning and nothing about the gene editing, is that correct?
Yes, yes,
Okay.
with the only 2 patients
Okay.
that I mentioned, it, one experiencing delayed hematopoietic recovery, and the other one developing HLH and ARDS in a situation of profound myelosuppression related to the busulfan administered as preparation to the procedure, because otherwise, without this myeloablation, the therapeutic benefit can be diluted.
Okay. And I have one more question, if you don't mind. So I am from the United States, where it is a poor population that has sickle cell disease and beta thalassemia. I don't know whether that is similar in Europe, but like, how much does this cost, and how is access going to be?
So thank you for asking, but the negotiation of the cost is something related to the company and just presenting the data. But in any case, before submission to the national or continental, in case of Europe, competent authority, I think that they cannot start to negotiate the price.
Thank you.
Thank you.
Thank you very much. I'm sure we'll have
Thank
a
you.
lot more questions when you present this in the symposia. Thank you very much
Thank
for
you so
coming
much.
today. Thank you.